Well, thank you everybody for attending this session of the GAP MASLD MASH Community Network. We're going to be, there we go. My name is Tessa Janovsky. I'm a PA from Arizona Liver Health here in Phoenix, Arizona. Today we're going to be talking about MASLD pharmacotherapy. So when we see our patients with MASH in clinic, we really need to be thinking about treating the entire metabolic syndrome. We have to really take all the different metabolic comorbidities into consideration when we are creating our treatment plans for these patients. First and foremost comes weight loss. And so we know that 7 to 10% weight loss can improve and reverse fibrosis, but unfortunately, only a minority of patients can achieve this and then sustain it. And so when we are talking about weight loss, we have some options. First and foremost, diet and physical activity and lifestyle modifications are always going to be part of the conversation with these patients. And so specifically as far as diet, watching their sugar intake, watching their carbohydrate intake. There's the option of weight loss medications that are on the market, which can be very good for some patients to lose weight. Not everybody loses weight on these patients, on these medications. So, but it is a good option, especially for patients with diabetes as well, to target both diabetes and weight loss. And then bariatric surgery is still an option for select patients, depending on their BMI, their comorbidities. Sometimes it can be a good option, but it's very patient specific as far as bariatric surgery. And so when we're talking about the GLP-1 receptor agonists, these medications should be chosen and dosed appropriately in patients with advanced liver disease. They, can be okay in patients with compensated MASH cirrhosis, but with careful monitoring and really education on increasing their protein intake as far as their diets go. But unfortunately, in decompensated cirrhosis, we worry about kind of what we call compound sarcopenia. So if they are losing weight with the GLP-1s, and they're also losing muscle mass as well, in combination with just the overall progression of the liver disease. So in patients with advanced liver disease, definitely need to be carefully considered in those patients. And as far as treating the patient as a whole, we really need to focus on their other metabolic risk factors. And so specifically treating their type 2 diabetes and lowering their cardiovascular risk. So making sure that their glucose levels are optimized, making sure that their blood pressure is well controlled on medication, and then also making sure that if they need a statin, they are on a statin. And so we know there's been tons of evidence that we know that NAFLD does not increase the risk of drug-induced liver injury from statins. And so statins are safe and we should be using them in our patients. And lastly, we want to target the disease itself. We want to target MASH. And so we have a few different liver-directed treatments that we will discuss today. And these focus specifically on the liver as far as decreasing inflammation in the liver and hopefully helping with fibrosis as well. So GLP-1 receptor agonists. So after food ingestion, what these medications do is basically they help to stimulate glucose-dependent insulin secretion and also suppresses glucagon. This dual action kind of helps regulate blood sugar levels by reducing glucose production from the liver and increasing the glucose uptake in other parts of the body. And so this leads to delayed gastric emptying, and it also promotes satiety and reduces energy intake. And so this together, all of these effects basically help to lower blood glucose levels and can cause weight loss. What is the role of these medications in our hepatology practice? So currently, semaglutide, it has completed phase 3 trials for MASH and is waiting for FDA approval as a kind of another indication to treat MASH. So hopefully we'll be expecting that maybe later this year or next year. In their trials, about 62% of patients in the semaglutide group, compared to 34% in the placebo, had resolution of steatohepatitis without worsening of fibrosis. And there was a reduction in liver fibrosis without worsening of steatohepatitis in about 36% of patients in semaglutide group, compared to about 22% in the placebo, which is about a 14-point delta there. And so how does this affect GI providers? And so it is a common side effect that these medications can delay gastric emptying. And so this can increase the risk of aspiration with anesthesia. And so before any sort of procedure, the dose should be held 7 days before. And if it has been taken within that 7 days, then maybe consider rescheduling the patient. And this goes for pretty much any surgery. As far as the anesthesia risk. And also, GLP-1s are known for having some GI side effects in some patients. And so really making a game plan with the patient as far as possible side effects and how to manage these better at home and hopefully mitigate a little bit of the side effects. Vitamin E. So vitamin E was a part of the PIVENS trial. This was in 2010. And I know we don't talk about vitamin E or pioglitazone as much anymore, but you'll still see patients who take these medications. And so it's important to know the data behind it and kind of the limitations associated with that. And so as far as the PIVENS trial, this was basically a 1-to-1-to-1 as far as vitamin E, pioglitazone versus placebo. And with vitamin E, approximately 43% of patients did show histological improvements of MASH. And this, as far as limitations with this was not studied in diabetic patients. And so this can be used in non-diabetic MASH patients without cirrhosis. And the 2023 AASLD guidelines do suggest vitamin E may improve MASH in non-diabetic individuals. However, in 2024, the EASL guidelines do not recommend it because there is limited efficacy on fibrosis and potential risks. And so the potential risks, there's concerns of the risk of vitamin E and bleeding, especially hemorrhagic stroke has been raised. But more prospective data is needed to kind of confirm this. There's also concern about demonstrating a relationship between vitamin E and prostate cancer, but that data is conflicting as well. But at the end of the day, it's still important that we discuss these considerations with our patients if we are regarding long-term use, if they are planning to be on this long-term. Moving on to pioglitazone, this, as far as in the PIVENS trial, it was a 30 milligram dose of pioglitazone. And so this can be considered in MASH patients with or without diabetes. And so in the PIVENS trial, there really was no significant benefit of pioglitazone over placebo in the primary outcome as far as improvement in histological features of MASH. And also, a potential risk with this is weight gain. And so the mean kind of weight gain among patients on this medication in the trial was about 10 pounds. And when if one of our main goals in treating patients with MASH is weight loss, this can be kind of conflicting. And so we still see pioglitazone used in patients with diabetes in endocrinology practices. And so it can be considered but also watching just the risk of weight gain, also possible edema, possibility of increased risk of bone fractures, especially in women. So careful patient consideration with pioglitazone as well. Moving on to resmetirom, in March of last year, resmetirom did receive FDA approval in conjunction with diet and exercise for the treatment of non-cirrhotic NASH with moderate to advanced liver fibrosis, so which is basically F2 and F3. Resmetirom is a thyroid hormone receptor beta agonist, and so it selectively binds to and activates that beta receptor in the liver. And it's important to note that it does not have any activation of the alpha, which can activate things like the heart, and so we don't have to worry about those other possible side effects because it only selectively activates the beta receptor. So, what is the relationship between the thyroid and the liver? And so what happens basically, the production of thyroid hormones is regulated by the hypothalamus and pituitary through the thyroid stimulating hormone. And so thyroid hormones have many, they regulate many different metabolic activities in several systems of the body, including the liver. The thyroid hormone has two major isoforms, which is the beta and the alpha. The beta is the predominant isoform in the liver. And so resmetirom is a thyroid hormone beta receptor agonist that selectively targets the liver. And so basically what it does is it activates the thyroid hormone receptor beta in the liver, the hepatocytes themselves, and kind of regulates the genes involved in oxidation of fatty acid and lipid metabolism. So this basically helps to break down more excess fat in the liver. And so how I describe it to patients is that it basically helps oxidize more fat in your liver. So it helps to defat the liver. It also increases mitochondrial biogenesis and removes basically unhealthy mitochondria. And so that leads to an increased capacity to metabolize free fatty acids. And so basically by reducing liver fat, it indirectly decreases inflammation associated with MASH. The trial that led to the approval of resmetirom was a trial called Maestro-NASH. So it is an ongoing phase 3 trial for the treatment of MASH. And so the trial was basically adults with biopsy confirmed NASH with a fibrosis score of F1B, F2, or F3. It's important to note that majority of these patients were F3. About 66% of these patients were biopsy proven F3, about 30% or 30% F2. And so they were randomized 1:1:1 ratio, receiving once daily resmetirom, 80 milligrams or 100 milligrams or placebo. And so the primary endpoints at week 52 was on biopsy NASH resolution, which included a reduction in the NAS or the NAFL activity score by 2 or more points with no worsening of fibrosis, or an improvement in or reduction in fibrosis by at least one stage without worsening NAS. And so first, looking at how well resmetirom is tolerated, it's pretty well tolerated. Nausea, diarrhea were most frequent with resmetirom rather than placebo. And the incidence of serious adverse events were pretty similar across 3 arms. In personal experience, I'll typically tell patients, nausea, diarrhea typically can peak between 2 to 4 weeks, and it will typically get better. It's pretty well tolerated. I have had very little problems with it, but it is important to just educate patients on these possible side effects before they start taking the medication, and to create a plan of action if they do experience any issues with the medication. So as far as the primary endpoint, and so both doses of the resmetirom, the 80 milligrams and 100 milligrams, were superior to placebo in achieving MASH resolution and improvement in fibrosis by at least one stage. So Taking a further look, we can see that compared to placebo, the resmetirom 100 milligrams improved NASH resolution with no worsening of fibrosis, about 29.9% of patients, 25.9% of patients in the 80 milligram arm. And then as far as fibrosis improvement by greater than or equal to 1 stage with no worsening of the NAS score is about 25% in the 100 milligram arm. And this study, as I mentioned, is ongoing. This will go out to about 54 months of treatment with resmetirom. And they also have a Maestro NASH outcome study, which is looking at resmetirom in well-compensated MASH cirrhosis as well, which is ongoing. So what patients do we want to treat or should we be thinking about when treating with resmetirom? Ideal patients for treatment is adults with non-cirrhotic MASH. It's important that we differentiate between F2, F3 versus F4. It is not FDA approved for cirrhosis due to MASH. And so patients with moderate to advanced liver fibrosis, stage 2 to 3, and remembering that it's approved in conjunction with a diet and exercise. And so every visit, as mentioned earlier, we should be talking to patients about how they're doing with dietary and lifestyle modifications, because that will help the medication as far as efficacy. So considerations as far as managing drug-to-drug interactions with resmetirom. Resmetirom is a CYP2C8 substrate, so concomitant use with a strong or moderate CYP2C8 inhibitor can increase resmetirom concentration. So medications to avoid here on the left, as far as medications that are tolerated but need to dose reduce medications, specifically Plavix or clopidogrel is on there. If they're, depending on their weight, if they're less than 100 kilograms, you reduce the dose to 60 milligrams. If they're greater than 100 kilograms, you would reduce it to 80. So still tolerated, but with a lower dose. And then as far as statin use, statins can be used. We just have to, there are maximum statin dose recommendations listed. So important to make sure that they're not on 80 milligrams of atorvastatin. It would definitely have to be lowered to 40. So how long do we treat patients with resmetirom? And so this discussion is ongoing. We're going to get more results as far as the study being ongoing to see how these patients do 2 to 3 years out. And so you will likely need to restage fibrosis and steatosis with either FibroScan, PDFF, through MRI or ELF. I would say whatever you used prior to treatment, kind of keep consistent with restaging. I'll typically tell my patients a year mark is where we'll really kind of look at before and after to see how they're benefiting, if they're benefiting from the medication. I will bring the patient back in 6 months to do a FibroScan as well, just to see kind of where the cap is as far as how much steatosis is on the liver. And so expert panels are actively working on this as far as seeing how often we need to check in on these patients and how long as far as duration of treatment is going to be needed for patients. And the question remains, so as with any new drug on the market, insurance coverage is key. And so widespread use of resmetirom, one of the aspects of that will be insurance coverage. And then how often do we stage these patients and how often do we monitor these patients? And will the need of duration of treatment recommendations, when to discontinue this medication and how close do we monitor those patients? And this is the first drug to market. It's not going to be the last drug to market. And so there's multiple other agents currently in clinical trials. And so in the future, there will likely be multiple medications that you will be able to use for your patients, which will hopefully lead to better outcomes for our patients with MASH with advanced fibrosis. So more exciting stuff to come as far as the treatment options for MASH. And then you can visit the GAP MASLD MASH Community Network for additional disease state education and webcasts for Resdifra if you use that QR. All right, a quick one today. Does anybody have any questions?